miniature goat from Madagascar. Now that we caught ourselves a goat, we can watch the farm show.
Welcome to the Farm Show. Tonight's guest is Heparin. Y'all know what time it is. Here's your host, Polly Pharmacy.
Thank you, everyone, and welcome to tonight's episode of the Farm Show, where we go in depth to discover medicine's true nature. Please help me welcome our guest tonight, Heparin.
Woo!
Welcome to the show, Heparin.
Thanks for having me, Polly. I'm really excited to be here.
We are happy to have you, and we know that what a busy drug you are, so thanks for taking the time to come out and visit with us.
Anytime, Polly.
I guess we will start at the beginning then. Do you have any aliases or any names that my viewers might know you by?
Well, Polly, I am just plain old heparin. However, I can be available in low molecular weight heparin, and then I could be called anaxaparin or Lovenox. My family consists of derivatives of me, and we are anticoagulants. That means we prevent clotting.
So how do you accomplish this, Heparin?
Well, Polly, in my original form, I am a long chain of polysaccharides. Ha, Polly. I have a unique active region comprised of a pentasaccharide or 5-sugar sequence that is randomly placed within the chain of many negatively charged groups. These negative charges make me highly polar, meaning I cannot easily cross membranes.
So how do you get your job done then?
I work by activating antithrombin. My pentasaccharide sequences binds with antithrombin, which then allows it to bind with either factor XA or thrombin. When they are bound, they are inactivated, which in turn suppresses their ability to form fibrin, the basic building block of clots.
That is fascinating. So you mentioned something about polarity and not being able to easily cross membranes earlier. How do you get it into the body to complete this life-saving task?
Well, like you said, due to my polarity and problems crossing membranes, I have to be given by injection, either IV or sub-Q. I tend to bind non-specifically to plasma proteins, mononuclear cells, and endothelial cells, so plasma levels can be highly variable and need to be closely monitored. I undergo hepatic metabolism and renal secretion, and my half-life is rather short, about 1.5 hours. My anticoagulant effects develop very quickly, within minutes of administration, but my duration of action is brief.
That is very interesting. Can you explain to us why you might be called into action?
I am the preferred anticoagulant for use during pregnancy because I cannot cross the placenta. I am also the preferred go-to drug in emergent situations like pulmonary embolism, evolving stroke, and deep vein thrombosis. I am also used with patients undergoing open heart surgery or renal dialysis to prevent coagulation in the devices that circulate the blood externally. Low doses of me are generally used after surgery to prevent post-operative venous thrombosis, and I can be used as an adjunct to thrombolytic therapy of acute myocardial infarction.
That is quite a resume, Heparin.
Thank you, Polly.
I imagine when dealing with prevention of clotting, there can be some adverse effects involved.
Indeed, Polly. Clotting is an essential mechanism in our body to prevent bleeding. Bleeding is the main complication of my use, occurring in about 10% of patients. Hemorrhage or bleeding can occur at any site and can be fatal. That is why it is very important that PTT, or partial thromboplastin time, be closely monitored. If bleeding occurs, I should be stopped immediately, and if I am involved in an overdose situation, protamine sulfate can be used to counteract my effects.
That sounds scary, but I guess a clot could be way more hazardous. Is there anything more?
Yes, Polly. My use puts patients at risk of spinal epidural hematoma and heparin-induced thrombocytopenia, or HIT. HIT is a potentially fatal immune-mediated disorder that actually promotes the formation of thrombi and is seen in about 1 to 3% of patients who receive heparin for more than 4 days. I can also cause hypersensitivity and allergic reactions in some patients.
Do you have any warnings or contraindications then?
Yes, I must be used with extreme caution in patients with a high likelihood of bleeding, like hemophiliacs. I am contraindicated for people with thrombocytopenia and uncontrolled bleeding, and I should be avoided immediately after surgery of the eye, brain, or spinal cord, or if lumbar puncture or regional anesthesia is going to be performed. People who are on aspirin or other platelet depressants should be closely monitored.
You have mentioned monitoring a couple of times. How is this done?
Well, Polly, patients using me have to have blood draws done to monitor the partial thromboplastin time, or PTT. This is done to keep my levels high enough to prevent thrombi, but low enough to prevent spontaneous bleeding. The normal PTT level is around 40 seconds. To reach therapeutic levels, PTT should be in the 60 to 80 second range. These levels should be checked every 4 to 6 hours and dosing adjusted accordingly.
Very interesting. Do you have any other facts you would like to share with us?
Well, I am prescribed in units, not milligrams like most drugs. The unit is an index of anticoagulant activity. Because I require constant monitoring, I am generally used in the hospital setting only. My other derivatives, like Lovenox, do not bind to thrombin, so they can be used more liberally without the necessity of constant testing.
You have been a very informative guest, and I am really glad you stopped by.
I am so glad I was able to shed some light on my usage, Polly. Thanks for having me.
This has been The Farm Show, brought to you by Team Ramrod.